Hello, I'm David Kerr, Professor of Cancer Medicine from University of Oxford. And what I'd like to discuss today, this excellent series of webinars that my great friend and colleague Ahmed Zawi has arranged, is to talk about optimizing dose selection for cancer medicine. You can see behind me the Dreaming Spires of Oxford. And I first came to Oxford as Professor of Clinical Pharmacology and Cancer Medicine. And what I hope to be able to do today is to be able to convince you that it's possible to use some simple scientific principles to optimize the dose of drugs that we deliver. Because when you think about it as oncologists, that's what we can control. We cannot control the genotype or phenotype of the cancer, but we can control how selectively and how carefully we deliver cancer medicines. So these are the topics that I'd like to discuss a little in more detail. Classical phase 1 trials to determine the maximum tolerated dose. These are something that I started doing 40 years ago. And basically, the essential trial structure hasn't really changed since then. Using a thing called an arithmetical progression called a Fibonacci scale, we treat 3 patients, we double the dose of the drug, we treat 3 patients, we double the dose of the drug until we see side effects happening. And then we increase drug dose by smaller increments until we reach a ceiling, so-called maximum tolerated dose. So the idea is that we continue to dose to the point at which the patients can tolerate the treatment no longer. A very classical design and one which has been used since the beginning of experimental chemotherapy. It's an important step from the laboratory bench to the patient's bedside, in which we take novel chemicals or gene therapies or vaccines or tyrosine kinase inhibitors, whatever the mechanism of action, they still go through this rather elementary toxicology-driven phase 1 trial design. Problem is that it's statistically very unstable. There are only 3 patients per dose level. And then when we get to the maximum tolerated dose, there may be 6 or 7 or 8. So think of that. We may be basing the treatment of thousands, tens of thousands of cancer patients, millions even, and a dose-finding schedule that may be based on a n equals 3. So a degree of statistical uncertainty, to say the very least. Not that that's caused us to change. It may be better to use Bayesian forecasting techniques, and there's some interesting ideas going on there. But the fundamental structure of how we introduce new drugs to the clinic hasn't really changed. People have thought of modifications over the past 40 years or so, and we've been at the forefront of testing some of these different approaches. Pharmacokinetics, so we measure, it's what the body does to the drug. So we measure the drug levels in the bloodstream, and we hope that we can define a therapeutic window. By that I mean there's a minimal plasma concentration that we want to achieve, because below that the drug would be ineffective. There's a maximum plasma concentration we want to achieve, because above that the drug will be very dangerously toxic. And between these 2 levels, we have the therapeutic window. So in an ideal setting, we would adjust the dose of the drug to achieve a preset plasma blood concentration level that gives optimal efficacy with tolerable toxicity. Problem with that approach, when we tried to apply it, was that, and because of intra and inter individual variation in pharmacokinetics, how we metabolize the drugs, how we excrete them, the variation was very, very large. So in a phase 1 trial, trying to dose escalate on the basis of plasma concentration proved impossible. Many of us tried, all of us failed. And that idea about defining a therapeutic window for anti-cancer drugs, attractive though it is really difficult. many of our drugs have got irreversible binding kinetics, and that makes it very difficult to build an appropriate mathematical model. Pharmacodynamic endpoints, that's when we try to titrate the biologically effective dose of the drug. Say we're inhibiting a particular kinase, can we, during the phase 1 trial or phase 2 trials, can we collect blood samples for pharmacokinetics, and can we collect cells that would allow us to see if we're inhibiting the target enzyme, if enzyme it is, to the right level. And we can do this using tumor biopsies. Difficult to do that frequently, but sometimes we use surrogate tissues, skin biopsies, collecting mucosal cells from the lining of the mouth. I remember once as a research fellow plucking eyebrow hairs, and if you do it properly, then you pluck out the cellular bulb at the base of the hair, which has got rapidly dividing cells. We were looking at an aurora kinase B inhibitor, and we thought this was a way, by plucking 5 eyebrow hairs, by examining the expression and degree of inhibition of the enzyme in the hair bulbs, that would give us a measure of pharmacodynamics. Was the drug acting in the way that we hoped it would? But again, despite collecting the 5 eyebrow hairs per time point, the degree of variation was too large for us to be able to interpret. But an attractive concept of titrating drug dose to a biological endpoint. What about randomizing 2 different doses against each other? This could be done in a phase 2 trial, in which we look at some measure of efficacy and, of course, toxicity, because we would always want to give the least toxic dose, which worked, which was effective. A good example of that comes from our own experience using folinic acid. Folinic acid is a vitamin-derived cofactor that moves methyl groups around within the cell. And we showed many years ago, as did others, that folinic acid can synergize with 5-fluorouracil. Molecular basis of this is well known. Folinic acid binds to and stabilizes the complex of 5-FU and its metabolite F-dump with the target enzyme thymidylate synthase. It's a lovely piece of cellular pharmacology, very clear sense of the mechanism of action. And what we did in our very large trial, 5,000 patients in the adjuvant setting, we compared high-dose folinic acid, conventional dose, 200 milligrams versus low dose, 20 milligrams, and we found no difference in efficacy whatsoever. So a tenfold reduction in cost, and yet still around the world, people conventionally give high-dose folinic acid, despite there being good randomized evidence, 5,000 patients, for goodness sake, showing that at a clinical level, at least in the adjuvant setting, colorectal cancer, it made no difference whatsoever. There are other good examples in phase 1 trials in which people like Mark Rattain, Ian Tannock have gone back and reanalyzed phase 1 trials and shown that we can detect efficacy, effectiveness at dose levels below the maximum tolerated dose. And yet, the groups involved in the trial continue to dose to the very highest level and select those as the drug treatment regimens that go forward, even though sometimes during the phase 1 trial, you can see that the drug is effective at earlier drug levels, at lower drug doses. But this is ignored somehow with that desire to treat almost to the point of maximum toxicity. This doesn't make sense, not in the modern world, I don't think. One other thing that we should consider is, how do we deliver the drugs? Do we really need to calculate the dose of our drugs with such precision that we use a multiplier of body surface area? The rationale for this is weak. As a clinical pharmacologist, I would want to be able to take account of our patients' hepatorenal function, the organs involved in metabolism or excretion. If we had measurements of those, then of course titrating drug dose, we do this with carboplatin, for example, but there are a few examples in which we titrate drug dose according to the function of those organs which are involved in metabolism and excretion. And therefore, I think we should be much more widely thinking about the concept of flat dosing, and to provide that dose within a single vial so that there's no wastage. Ian Tannock did some work looking at delivery of immune checkpoint inhibitors and the waste, the amount of drug that's often left over in the vial when we try to calculate it according to weight or body surface area. One could save millions and millions of dollars just by flat dosing and using the entire contents of the carefully curated vials. The other area that I'm interested in is pharmacogenetics. We've done a lot of work using genome-wide association studies in which we look at germline genetic variants, often in the enzymes involved in metabolizing, deactivating the cancer drugs that we use in the clinic. And of course, if we could identify, using genetic techniques, those patients who were at high risk of developing serious life-threatening side effects of chemotherapy, we could identify these patients before they're treated, and in so doing, we would be able to significantly reduce death rate, improve safety, reduce the number of patients admitted to hospital with serious side effects, and save the health economy money. It's very expensive for us as an oncology community to take care of cancer patients who are admitted with life-threatening toxicity. And again, we've shown this in our own work with 5-fluorouracil and genetic variants of an enzyme called dihydropyrimidine dehydrogenase, and a couple of other proteins that we've discovered in our genetic studies. So we have every patient in the United Kingdom has a genetic test before they receive treatment with 5-FU or capecitabine. And real-world evidence shows that we reduce the death rate from fluoropyrimidine toxicity, we reduce hospital admissions, and in our nationalised healthcare service, we significantly reduce costs. So these are some of the areas that we should be thinking about when we're trying to optimize dose selection for our patients. If I could ask you just to read this for a moment. This is a work of Mark Brattain that I mentioned a little earlier. He looked at a range of orally available cancer drugs, many of them tyrosine kinase inhibitors, the modern targeted oral drugs. And what he found was that by lowering the dose, a reduction in treatment frequency, the cost of more than half these drugs could be very significantly reduced, but without diminished efficacy. So exactly the point that I was making earlier on, that if we analyze the phase 1 trials very carefully and thoughtfully, then in a very significant number of cases, we could reduce the dose of the drug, maintain efficacy, and as Mark and his group worked out, potentially save remarkably billions of dollars. So for all those young oncologists, I know you get excited about molecular genetics. I know you get excited about immunology, but all of you, please remember the concept of dose. That's what we can control together. I'd like all of you to think a little about some good old-fashioned clinical pharmacology. and some of the basics like flat dosing rather than the overcomplicated dosing regimes we use around body surface area. I do hope you've had a chance to listen to this brief lecture. I know that you're going to enjoy the webinar series, unquestionably, but I hope what this does is cause you to think a little about how we best control dose. Thank you very much indeed for listening.